Welcome, everyone, to the Beauty and the Surgeon podcast. I'm Amy. I'm a nutritional therapy counselor, and I'm joined today with Dr. Jason Martin. He's a board-certified plastic and reconstructive surgeon and my co-host of the most.
I don't know if I'm the most, but we are talking about a problem today when you have an abundance of something and you need that reduced.
What do they call that? A bounty of riches? Bounty of riches?
Bounty of riches.
Bounty of riches. It was a Monty Python, like she has amazing tracts of land. We're talking about that.
You know it's bad when you start throwing out Monty Python.
Yeah. Yes. So we're talking about breast reduction.
Breast reduction. It's like one of the most common surgeries we do.
The cups that floweth over.
I know. And it's always a debate. It seems like that women who have very large breasts definitely want a reduction, and their significant others don't want them to have a reduction. So a breast reduction probably has the highest satisfaction rate of anything we do in
I would
plastic
agree
surgery.
with that. Yep, by far. The happiest patients.
The happiest, because it's a huge
Yes.
functional improvement to their life.
It makes their life better. And for a lot of women, they will maybe wait until after they have children to have this done. So, they're in their late 30s, early 40s, and they have literally spent 20 years of their life waiting for this surgery.
And you don't, if you really get into the down and dirty of what they have to do to carry around this weight. I mean, they're wearing 2 sports bras or sometimes 3. Mm-hmm. It's a kind of a mess.
Chronic neck and back pain.
Oh, yeah.
It's very challenging. Clothing options are extremely limited. Just the way your body looks when you are extremely top heavy. It's hard to tell you even have a shape underneath all that boob.
And then on top of that, you layer the self-perception, the fact that you think that everyone's staring at your super large breast. They hurt. You get rashes. It's just overall, it's not a great situation.
Yeah, and a lot of that starts for some women in adolescence, because they are kind of maybe they stand out amongst their peers if they develop very young and they develop very large. They absolutely do stand out amongst their peers. So that does kind of stick with a person. So it is when you say that this is we're talking about a problem today. I mean, in most cases with plastic surgery, we're not really talking about a problem as much as,
Yeah, so Amy and I had that discussion recently about what we do and how we help people, because we truly believe we help people. But, there's some things we do in cosmetic surgery that are absolutely not necessary. I mean, that's for sure.
Oh, yeah.
Like a facelift, even though our
It's
patients
elective medicine.
It's elective.
Yeah.
This kind of gets into the part that's more reconstructive because it helps people physically. And that you're getting into the reconstructive category because in some cases insurances cover breast reduction.
Yeah, our breast reduction yesterday was covered by insurance.
No insurance covers a facelift.
Nope. Or a tummy tuck or liposuction.
Never. Even though people come in and say, well, I think I'm going to submit it to my insurance. I'm like, you should definitely do that. But they're going to say no. But a breast reduction, if you fit the criteria, and we'll talk about some of that today, it will be approved because the insurance companies know that you can improve their quality of life. They exercise more. They have less bouts of depression. They have less chronic problems, medical problems like back pain,
headaches,
that cost money for the insurance companies. So breast reduction is, and I'm surprised we have not done an episode on breast reduction.
Yeah.
We both were like, well, we've done that.
How have we not done that?
How have we not done that?
Yeah.
It's probably one of the most standard things that plastic surgeons do across the country. And it relates to beauty, and it relates to health, and all the things that we talk about. Yeah. So here we are, breast reduction.
Let's talk about the anatomy of the breast.
All right, you go ahead, Amy.
So if
you're a woman and you're an anatomist.
Yes, well.
So you take care of business.
So if you'd like to see the slides associated with this podcast, you can find those on our YouTube channel at Jason Martin MD. So this first slide is just showing a picture of basically a cross section. So what's going on the chest wall essentially. So we've got the ribs, we have some muscles, and then on top of that we have what makes up the breast. So it's a combination of obviously nerves and blood vessels that are innervating the breast and the nipple. There's fat that kind of encircles the entire breast, and then milk ducts. So it's a combination of all of those things, the mammary glands that are all kind of making up the breast tissue itself.
And when you're younger, your breast is more fibrous. It's more the glands. And as you get older, the fibrous stuff gets replaced by fat. Obviously, when you gain weight, the fat becomes more prominent in your breast. So that's why women post-pregnancy, they get this hypertrophy or this expansion of their breast with milk. When the milk comes in, there was that name. We talked about that. And
the witch's milk.
Witch's milk. When the witch's milk comes in, and then it involutes or goes away, and you're left more with fat than less of the gland.
Yeah.
So, and you could see that when you go in. I mean, a young person, when you do a breast reduction, it's a lot tougher tissue. It's more condensed. An older person, there's a lot more fat involved.
Well, and some of it too is just as we age, there becomes laxity to all of these tissues as well. So laxity of the actual ligaments that support the breast.
Do you remember the names of those ligaments?
No, and I was just thinking that I'm like, I knew you were going to ask.
Cooper's ligaments.
The ones that support the breast?
Yeah.
Yeah. So those loosen.
So, can you imagine being Dr. Cooper?
Right? You got the breast ligaments
And
named
like
after you?
you're literally, your namesake is the ligaments that are in women's breasts.
Is that better than being Dr. Kegel?
I don't know about that.
Yeah, there are a lot of other things. So the same thing happens to those tissues, though. So like our fat cells, everything in our body, like as we age, like those bonds that kind of hold things tightly together when we're young do start to loosen up. So add that all together, and someone who has very large breasts to begin with, like those ligaments are under extreme strain.
And they stretch.
They're stretching too, so the heaviness is just going to continue to kind of pull down.
Right, so if you have heavy breasts, they'll tend to want to droop at what we call ptosis. And that becomes even more of a problem. That's where you get the rashes, because the breasts flop down on your upper belly, and it creates a moist area, and that's where they get the rashes. It's where you get the mastodynia, which is breast pain, and that's where you really start to get the problems with kyphosis, or kind of bent over. Imagine me, the surgeon, always bent over doing surgery. That's why I have somewhat of a kyphotic stance. If you can watch the YouTube channel, I'm really sitting up straight right at this moment. You get that with most women who have large breasts.
Yes. Yeah, I have somewhat of a kind of, and it's gravity. It's pulling down.
Pulling down.
It's a lot to hold right on the front of your torso. I mean, you think about it, like as you think about how your body stacks up as a structure, we're kind of equally balanced for the most part. Having a large amount of weight in the very top third of your body essentially is a lot to kind of just pulling you down. Gravity's working hard on that essentially. So the stats from the American Society of Plastic Surgeons this is from 2018 still?
Yeah, ASAPs.
Yes, ASAP, sorry.
Yeah.
From 2018, breast reduction in women was actually the fourth most common
breast surgery.
Breast surgery? Yeah.
So breast augmentation, and then breast lift.
Oh, so it was the third.
It's third, excuse me.
Yeah, it was the third.
Yeah.
They're not in order of.
But it's pretty common. It's like 85, 90,000 cases. It was ranked 7th in 2017. Now it was ranked 6th in 2018. It's very common surgery, and it is fairly universal. If you go into a plastic surgeon's office, most of them do a breast reduction.
Mm-hmm. Yeah, and we'll probably talk about that more. So it is a common surgery.
Yep. The criteria when you want to get it covered by insurance, and this is like a common question, can really differ between insurance companies. If you look on our YouTube channel, I wrote this down. This is kind of a busy slide, but it's really helpful. And I think anyone watching this who wants a breast reduction and really wants to look at the insurance component, look at this slide. You'll see that there's so many different things, right? There's the rashes or kind of excoriations underneath the breast. You have really functional impairment. And don't they usually require physical therapy?
They do, and
Okay.
I added that to one of the slides. I didn't see it on this one, but that absolutely is something that even if you have all of these other things, your insurance company is going to see that you have tried other things, so complementary and alternative medicine, or CAM, to address them.
Got it.
So you can't just say I have chronic headaches. You have to say I have chronic headaches and I've tried Botox injections for them, or I've tried physical therapy for them, or I've gone to the chiropractor. Like you have to prove, and it varies by insurance company how long of a time of trying these CAM treatments are. Most of them are going to require at least 6 months of CAM.
Yeah, 2, 4, 6 months.
Yep.
Yeah. I mean, there's so many different symptoms. There's extremity symptoms, nerve compression, kyphosis, which is the hunched over kind of older person stance, chronic breast pain, upper back and shoulder pain, grooving on the shoulder straps, headaches. And then you get into how much tissue they want you to remove with the breast reduction, and we'll talk about that. It gets a little bit complicated. So everyone listening, if you want to get it covered through insurance, you better be willing to be flexible, because the insurance will make you jump through hoops. That's their job, is to make you try to do alternative things before they pay any money.
Which makes sense.
I'm not throwing shade, just saying. Definitely weight loss is important to them, and we'll talk about that too. So your body surface area or your BMI does matter to them, and specifically your weight and height. And then they require, if you're going to do a breast reduction, you better make it worthwhile. So they require a certain amount of weight per your body surface area.
Mm-hmm. Yeah, and there's a formula for that, the Schnur.
The Schnur.
So this is...
Again, would you want to be Dr. Schnur?
Dr. Schnur, you created the chart.
The chart that they all go to. And, and if you look, again, on our YouTube channel, on our slide, you'll see the body surface area, and there's a calculation for that, which Amy does in her head, which is apparently is your weight to some power times your height to some power times 0.007184.
Body surface area by weight by height in kilograms.
You do that in your head.
In centimeters surface area. Yeah. Oh, yeah.
You do your BSA.
Yeah, nothing says math whiz like someone severely dyslexic.
I know. I mean, it's so funny now in the way that things are in the world, because if you could do that in your head, it's amazing. But I mean, it takes you like 3 seconds on Google to get the BSA calculator.
Yep. Well, and our EMR does it for you. You put their weight in, height in, and it does it for you.
It does the Schnur for us.
It does the Schnur. So it makes sense, right? Because your insurance company wants to make sure that you're not just overweight. You know, and I hate to say that because I'm not trying to body shame anyone by any means, but breast tissue, like we talked about, is a lot fat. And so if you are, grossly overweight, your breasts are going most likely to be larger by default. It doesn't mean that they're abnormally large for your overall body at that point. So it's a way for the insurance company just to kind of lay it out there, and have some parameters that are replicatable by any doctor.
And we didn't talk about that in the wound healing or the scar episode, but the reality for wound healing and scars and just healing from any surgery, obesity is a risk factor for having problems. So there is some safety component to this that they're trying to protect the patients from doing basically an elective procedure. Mm-hmm. It is elective.
Not life-saving.
Yeah. And to avoid that, and just in case you're not a good candidate for it.
Correct.
So they take your body surface area. The more surface area you have, the more weight you have to take out, the more breast tissue you have to take out.
Mm-hmm. Yeah.
And we weigh it at the time of surgery, just so you know. We weigh the specimens, and I already know what I need to do. So I'm like taking out, you need to go a little bit more, and I'll take a little bit more tissue.
Yeah. So just to review the documentation that your doctor should note, essentially when you come in, obviously the date of the evaluation, the decision to have surgery or to, that's the weight you want to go, your height and weight, your body surface area, photographs. And the photographs, it's really important to take pictures of grooving is specifically something that the insurance company will want to see.
If you go, this sounds crazy, but if you go to a consult and the doctor doesn't take photographs of you, I would have a problem with that, because they're going to need that most likely for evidence for the insurance company.
Yeah. And I always remind women, which most women who have very large breasts don't struggle with wearing a bra every day, but remind women, definitely wear a bra. Some women would come in and will have not worn a bra for a couple of days because they are like embarrassed by the grooving because they know they're going to be showing it to someone. I'm like, no, like wear a bra when you come to your consult so I can take pictures of that grooving.
Pre-groove.
Yeah.
Pre-groove.
And I know I have a family member who had a breast reduction, and she wanted, when she was getting married, she wanted to have, her dress was sleeveless. And she had to stop wearing a bra for like 5 days before her wedding so that the grooving would go away.
Wow.
It was days. So she had to have a custom-made like bustier to wear under her dress. But she could wear a bra for days, or else she had these deep grooves. And this was a young woman. So she had her breast reduction, is super happy. It wasn't with us because this was years ago. But yeah, these grooves don't just, for most women, the grooves are there, but definitely your doctor should be taking pictures of that.
And then again, just to kind of get through the insurance stuff, there definitely should be documentation of alternative treatments, as Amy talked about before: physical therapy, occupational therapy, chiropractor, et cetera.
Massage therapy, that's usually acupuncture even. Insurance companies are definitely broadening their view of what is acceptable CAM, but having letters from those providers saying that they've treated you for X amount of time, X amount of sessions, no improvement in your symptoms, all those things, any kind of helpful information you can bring to your surgeon is going to be helpful to kind of building your case for your insurance
company. And I would
company.
highly advise you, the patient, to actually get some of these things done before you even go see your plastic surgeon.
Absolutely. Like, have all this stuff. You should have, if you've been having these treatments, like you have it. So let's talk about the interesting part of breast reduction that everybody probably wants to know about is, how do you actually do it? What are your approaches?
Because what is the biggest concern with breast reduction?
Scars.
Yeah.
Especially for young women, because this is something that women will seek out in their early 20s. No woman in her early 20s is really super excited about having scars on her breast.
I get it. Do you get it?
Absolutely. That's why, 100%.
So, and again, go back to our episode on scar formation. You can understand why we do have scars. And there's 3 different approaches. There's an incision around your areola, so a circular scar. There's a vertical scar, which is a lollipop around the areola and straight down the midline of the breast below the nipple and areola. And then the scar that I think people know in their heads, the anchor scar. So it's around the areola, straight down the midline of the breast, and then along your fold. Imagine an anchor for a boat.
Do boats still use anchors? I mean, they have to, right? Like, you still got to stop yourself in the ocean.
I don't know. Isn't there an app for that? You just press the app and your boat stops.
I'd like my boat to just drop a pin.
Yeah.
So, does that pin not hold your boat in place?
It's so funny to think about all those kind of things that when you grew up, they were like such a given, but maybe there is an app for.
Oh, I'm sure you
anchor.
Still need the anchor. I mean, the ocean still moves.
I know, but the phone controls the anchor.
Right,
going
like
up and
anchor down.
Anyways, so most of the time we try to push toward the vertical scar. The one around the areola, it's very difficult to do enough of a reduction to make a difference, and that probably won't be covered by your insurance. The vertical scar is preferred because obviously there's less scarring. The vertical scar is great, and we actually enjoy doing that surgery. We have great results from it. This is a key point. You will not get enough reduction on the outside of your breast, which we call the lateral side, if you have a lot of excess tissue there that goes into your armpit area and then goes along your bra line. If you have a lot of stuff there, no matter what someone tells you, a vertical is probably not going to cover that. Mm-hmm. The second thing it doesn't cover is if someone has a lot of extra skin, okay? So the vertical can chase out skin, but not probably to a degree that you need. And the third thing the vertical doesn't do very well is if your fold, your inframammary fold, the base of your breast is really low. A lot of women have that. Over time, with the weight of the heavy breast, it lowers their fold. So their fold is like halfway to their belly button already.
Or basically at their belly button sometimes, so low.
You know, we go to conferences, plastic surgeons sit there and debate this at dinner, and it's just super boring. But just in most cases, you're going to need the anchor incision if you have one.
So much shade at other plastic surgeons. I hate them. So much
I like Nils. I like you.
Yeah, okay. Yeah. I think I
have no problem telling you that.
For women, if you're kind of thinking about what type of incision you might need, if your breasts are very wide, regardless of their size, if you think about it with a breast reduction, we really want to maintain a nice round shape to the breast. So to do that, we kind of need to pull the breast in and up. So if you have a very wide base breast, you're going to need that anchor incision just to kind of bring it all back to the midline a little bit. You don't want a weird flat triangular shaped breast at the end, or a pointing, like a breast that's not a weird kind of pinchy look. If you were just pulling it in the center, I think it makes sense to most people how that would maybe make a weird effect.
And there's some surgeons that do verticals all the time, and I mean, I love that. I love the fact that they're trying to push the envelope, and it's easier to sell if you sell to someone that have a less scarring reduction. I mean,
but you're going to have this weird breast tail.
Yeah, I mean, but at some point there's a limit to where you can go with the vertical, just so you understand that. If you go in someplace and you have size triple G breasts that are super ptotic or droopy, and they tell you you're going to do a vertical, then I would, it's not going to happen. Nope. And it's not going to look good if they try.
And that anchor scar is ultimately hidden. It's in the inframammary fold. So it's...
And I will say, sorry to interrupt, but there's a limitation on how much you can reduce with a vertical, or the less scarring reduction. So a lot of women come in and they're like, look, if I'm going to do this, I want it reduced. I don't want to deal with this in the future. I want a C cup, and I want it to be there. And the vertical does limit you in that sense of how much you can remove, but it's a great option. If you look on our YouTube channel, we show you can do these really cool kind of pedicled procedures, and the pedicle is what the nipple and areola is supported on. You rotate that up, all the breast gets moved up, and you get that midline scar, which heals really well and tends to be hidden really well too.
Yeah.
One of the things is, just FYI, with the vertical, if you try to do a larger reduction, which is definitely possible, the vertical scar tends to go past your fold, going down toward your belly button and onto your abdominal wall. And a lot of women don't like that because it can show when you wear a bikini. So then what we do is we curve it around along the fold. So it goes down, and then it takes a right or a left and goes out toward the outside of your chest. That's great too, but if you're doing that, why don't you just do the whole fold incision?
Do the anchor, yep. Yeah, and I think, it's probably way less visible. Even if you have a rather lengthy anchor incision because you had a very wide breast, that's still under your breast essentially. Right. Whereas if we have to drag that vertical down, it does show. And like having two weird straight lines poking down out of your swimsuit, like that is a little weird.
And we've seen it.
Yeah.
So I would say always err toward the vertical reduction, but have a low threshold to go to the anchor. If a notable or if at least an effective reduction is what you want.
Yeah.
So
Or you have a very wide breast.
Or you have a real wide breast that has a lot of stuff on the outside.
Like your breast sits really far to the side.
Real far to the side, and the breast tissue and the fat's going over into your bra line, and that's what you hate. There's a lot of women that really hate that. Like you can't get that without doing an anchor incision.
Yeah, and sometimes the anchor can be really small too. And when we do a breast augmentation, we're making an incision in that same place in that inframammary fold. So it's not.
There's differing amounts of anchor scars, the scar in your fold.
And sometimes they can be small.
Again, we believe in less invasive surgery. We embrace all the newest techniques, but if you have to have an anchor incision, don't just think that's the worst thing in the world.
Yeah.
But we get it. Again, the anchor incision puts an incision or a scar along the fold, and that not only takes excess breast tissue out from a horizontal standpoint, but it takes it out from a vertical standpoint. So all different dimensions of your breast, it reduces it down.
Yeah, kind of pulls it all back in.
Yep.
Yeah.
If you look again on our YouTube channel, we show.
I don't know why this woman has her arms up in the air.
I know.
You find the craziest pictures.
I know.
Like this woman and the woman who has to pee on the abdominoplasty one.
I know. And I like this because I was wondering why her hands are in the air.
She's so excited.
Like she's at a bank and someone's robbing it. Like, put your hands in the air.
I'm in the middle of surgery, but okay.
Yeah. And then even if you look on there, the keyhole is super small. I mean, none of this makes any sense. I think this is probably more of a mastopexy. But the reason why you kind of get the idea where I like this because it shows you why you have to take out that extra skin and soft tissue.
To really bring things back up. Yeah, the vertical, the lines here really help show, the horizontal lift essentially that you get with that anchor. Really, can you bring the whole breast back up? And again, a lot of women don't even care about the scar with this surgery because it's like, just get it done.
And I'll make it real clear. I mean, we're very prideful about our scars. It's a big part of what I do with surgery, the way I close it. The markings for breast reduction surgery are extremely important. So when you go to surgery in the morning, and sometimes we'll do it the day before, but most often in the morning, you go to the preoperative area, the surgeon will sit down and mark you, and that usually takes 20 to 30 minutes.
Oh, easily. I mean, it could take even longer.
We have to measure it out, make sure it's symmetrical from one side to the other. I mark the midline. If you go on our Instagram page, at Jason Martin MD, I have the markings for breast reduction.
Or Facebook. They're not all on Facebook because Facebook's weird, but they're all on Instagram.
Instagram, yeah. We got shut down on Facebook.
Yeah, Facebook knocked a couple
because we showed some female anatomy, but everyone can be in their Lululemon posing shorts and show seductive poses, but we can't show like a patient.
Surgical markings. Yeah. But
Thank
Jason
you.
Martin MD, at Jason Martin MD on
salacious.
Instagram. Yeah.
Us and our educational stands.
Yeah.
All right.
But it shows how complex
people can handle the education, but they can handle the overt sexuality, whatever. So if you go on our Instagram channel, you can see actually the markings and what we do. Mark the midline of the chest. Mark the midline of the breast. Mark the fold. And if you watch on YouTube, I'm actually doing it right now in my mind. Then we mark where we want to lift the nipple and areola to. Then we do the vertical markings, and then we do the fold, which would be the anchor incision if we need it, or carry that down to do a vertical incision.
And sometimes we'll even, when it's a really kind of more complex breast reduction, we'll have a patient come in to the office the night before surgery and we'll kind of pre-mark them just because it does take so long. 20
or 30 minutes. And that can be really disorienting. You're going to the surgery facility, and the ones we do at our hospital, they have the rooms. So you have privacy, nice. But some places have like curtains.
You're in a bay.
And you're sitting there and you're hearing like, the guy next door is getting a heart transplant and you're like...
Right.
Getting marked for your breast reduction. It's not great. So if we're ever in that situation, we'll mark them beforehand. It's really important that you go into these surgeries in a positive mind frame, state of mind, so that you're positive and you feel comfortable. Because it can be really nerve-wracking, especially going for something that you're putting scars on the breast.
Right. Well, and even when surgery is elective, it's still surgery. Like it's still nervous.
Yeah.
It still makes you nervous. So
Amy, let's talk about recovery.
So recovery from breast reduction is actually easier than recovery from a breast augmentation because we're not doing anything with the muscle wall. So it's really just incisional pain that you're dealing with. And incisional pain is not as bad as like when we're, having to do like a muscle repair on an abdominoplasty or, going up under the pectoralis muscle to put a breast implant in. So most patients are very really tolerate the pain well. Maybe a day or two of pain medication at most for most women. A lot of your symptoms sometimes are improved immediately following surgery. Like you may be wrapped up, but you have had, hundreds of grams of breast tissue removed, and some of your discomfort is so much better that it makes dealing with some pain right after surgery not so bad. If we have to do a little bit of liposuction with a breast reduction, like out on the outsides, if the breast kind of falls that way, that tends to be more uncomfortable than anything else.
Yeah,
So,
the patients do not have a lot of pain.
No.
Universally.
Yeah, and you can typically shower. We don't typically use drains for breast reductions. It's extremely rare for us to put in drains. So you can usually shower the next day, which also is helpful. You do, kind of have to protect the area, obviously. We don't want you raising your arms super high over your head or lifting anything heavy to make sure your scars look good. So that's really, it's not a terrible recovery as far as recovery from plastic surgery goes. It's a pretty simple recovery.
And how long does it take for the scars to really kind of lighten up so they can feel maybe less, it's less noticeable, maybe feel better?
I would tell people a year, and that's just being very honest, that your scars are going to take a long time to completely remodel. Some of the areas will be less visible more quickly. Specifically, the incision directly around the areola tends to fade a little faster.
Because there's less tension there.
Yep, very little tension. It's also really delicate skin. It's very well vascularized. Like there's a lot of blood flow, obviously, to your nipple and areola. So that tends to heal really fast. The vertical and the anchor tend to take a little bit longer, up to a year. And that's why it's really important to make sure that you're following your post-op instructions, making sure you're keeping those incisions out of the sun. Even wearing a swimsuit, you need to be putting sunscreen on them as soon as you're cleared to do that when you're out in the sun.
Is it? We tell our patients?
Yes,
that?
it is.
Oh, okay.
100% it is. Like your swimsuit, if you're wearing a bikini, that is not protecting your scars.
I don't get to be part of these discussions.
You can be.
Okay.
Come talk about sunscreen use. Yeah. Come on in. We'll talk about what it's like to wear a bikini.
Let me go grab
breast
Dr.
reduction.
Martin real quick.
Yeah, he wants to hear what we talk about.
Yeah.
We're talking about sun protection, but those things are going to make your scars as best as they can possibly be. And obviously we're very sensitive to that. Using some silicone creams after is sometimes very helpful. Some women tolerate the surgical tapes on their breasts well. That skin is delicate though, so it's kind of, we usually will start with the creams first, and then, if someone wants to try some tapes, but
yeah,
it really,
the silicone creams really, and we have a silicone cream that actually has an SPF in it,
Yes.
so you can kill two birds with one stone.
highly recommend that one. Yep. Giving you that extra protection.
So it's not painful. Recovery is pretty easy. The stuff that you see after surgery, the scars tend to heal fast. The stuff you don't see, like your inframammary fold, the fold along the base of your breast, tends to be red longer. And that's just because where the undergarments sit, and just because that can create a little moisture in there.
Well, there can still be skin on skin there. Even when we've reduced the breast quite a bit, some women are still going to have breast that hangs over their inframammary fold, just because of the size.
There's not a lot of risk with this surgery. Infection rates tend to be pretty low because it's a vascular area. Obviously, if you have diabetes or you're severely obese or other notable medical conditions, then to be honest with you, you probably shouldn't do this surgery. But that puts you at higher risk for healing. The big concern after the surgery is the blood flow to the nipple and areola, and that is really it's technique driven, right? I mean, it's conceivable someone could have a problem because they have different anatomy, but it should be well designed by your surgeon. If it's well designed, your blood flow to your nipple and areola afterwards will be okay.
Yeah, I think probably the biggest question that women maybe under 40 ask us with a breast reduction is, can I breastfeed?
Yeah, and it depends on the design of the surgery. The way we do it, we use, and you can write this down, so when you go into your doctor's office, your surgeon's office, we use a superior medial pedicle, so up and toward the midline, and that has the best blood supply, and will salvage at least some of those ducts that go into the nipple and areola that allow you to breastfeed, but not guaranteed at all. Also, with a breast reduction, this is important, sensation to the nipple may be changed, and it probably should be because you're violating a big part of the anatomy of your breast. So if nipple and areola sensation is very integral to your functioning in life, then I would not do a breast reduction.
Yeah, or breast lift. And we tell women that. I mean, even though the nerves that innervate your nipple and areola are coming from above, there's absolutely no guarantee.
Yeah, they come from the sides, above. I mean, so, I think it's really important that you think through this, but by far, some of our happiest patients are breast reduction patients. And, it really just comes from a functional improvement, and they feel like a weight has been lifted off their shoulders,
Yes.
and literally has.
It has been.
Like pounds.
Yes.
They're so happy.
Yeah.
Now, truth be told, it's one of the higher, like from a litigious standpoint, it's like has one of the higher lawsuit rates of all the surgeries we do, because unfortunately, not all plastic surgeons really sit down and talk to their patients about where the scars are going to be located and things like that. So they may not educate the patient, right? And the patient afterwards has a problem with their scars. But usually the lawsuits don't come from that. They come from the blood supply issues or bad wound healing issues, real things that cause chronic problems. And by and large, in most cases, that's from the surgery design. It's really important that you go to a board certified plastic surgeon, okay? And I'm emphasizing plastic surgeon because that's what plastic surgeons do, not an ENT surgeon, not an ophthalmologist, not your friend down the street who says he does these sometimes. A board-certified plastic surgeon that also, specializes in breast surgery. Not all plastic surgeons do breast surgery all the time.
Nope.
Right?
Yeah, they don't. And even though there may not be as many breast reductions done by the numbers every year, a mastopexy or breast lift, a doctor who does a lot of breast lifts and maybe a small amount of breast reductions is still going to be a great option for a board-certified plastic surgeon.
So you take an office like ours that's primarily cosmetic, so we're not really in the insurance world. That's not where our focus is, but we do really good breast reductions because we do so many breast lifts, or we'll do reductions that don't qualify for insurance.
Or insurances that it is actually, unfortunately, it is not one of the codes that cannot be excluded. So insurance companies can choose.
Wait, so what did you just say there?
So there are
codes. You just
did
a double negative.
Right. There can't not be. There are specific codes that.
You got codes in different area codes?
I got lots of area codes. So there are specific billing codes that cannot be excluded by your employer essentially on your insurance policy. So things like covering for breast cancer.
Right.
But breast reduction is one that your plan can essentially opt out of it. So your specific employer or your specific plan.
Stinks. So like patients come in and oh my gosh.
Yeah. So that's why when I initially before I even start a pre-certification, what you do first is check to see if that code is even a code that is covered by their policy.
What's the code? Do you remember?
19318.
All right, we're going to check that.
Or 19316. It's one or the other.
Please write in, see if Amy was correct.
16 and 18.
Just do a CPT code, Google search.
Mastopexy's one.
Reduction mammoplasty.
Breast reduction's the other.
Mamma, breast, plasty. Yeah.
Yeah, so it's one or the other. One is lift, one is reduction. 316 or 318. Yeah.
But I think that the kind of legal litigious stuff is really remote from the past because some of these.
That's not something that's discussed in like the stuff I do.
No, I know.
This
is more. I mean, I'm getting old now. It's for my training, and that's because we didn't have these newer techniques. I mean, the techniques we have now have less scarring, improved viability of the nipple and areola. For sure, what I like about using a superior medial pedicle is the breast looks like a normal breast. Actually has really nice contour.
Shape is really good.
So, and then also, truth be told, a lot of the problems in breast reductions in the past were they were allowing patients that weren't the best candidates to do them, and the insurance companies were covering it. People with high BMIs, people with diabetes and smoking. And nowadays, the insurance companies are like, no. And in some ways, that's good because it forces you to either lose weight, and we are compassionate for people that struggle with weight, just so you know that. So we're not saying that's a bad thing, but you have to exhaust every effort you can. And it forces people to stop doing activities that would increase your comorbidity afterwards or the problems after surgery. So like smoking, drinking, or everything else.
I think one other common concern of women when we consult for breast reduction is, will it come back?
It can.
It can.
Because you remember, you leave fat there, fat grows when you get fat.
Right. And it's estrogen driven, so there is a component that is hormonally regulating breast growth, like your kind of preset size, which is why siblings, maybe sisters, one is, a triple F and one is a barely A. What's going on there? It's in their genetic code.
When you say what's going on there, I always feel like you're like Jerry Seinfeld. Like, what's the matter with that one?
What's the matter with that one? Why didn't her boobs grow?
You have one sister. She has an A.
She took all the breast genes.
Yeah, why does that happen?
Right.
I mean, it's in their DNA.
Yeah.
It has to be.
And I would say we've actually seen that happen more frequently in men when we're doing gynecomastia as essentially a breast reduction. It's a reduction of the breast tissue who have a regrowth that is more hormonally driven. Like they might have some hormonal imbalances, and that's why that breast tissue continues to grow even when you remove it. So the same could hypothetically happen in women. Pregnancies. If you have this done in your early 20s and you have pregnancies, your breasts are going to grow and they might not shrink back to where you hope they would. And that's another thing.
So one of the big benefits of a breast reduction is it lifts your breast. I mean, breast reduction patients love that. They're like, thank God these things aren't hanging down. Right. I can walk around without a bra on and a t-shirt, and they just feel a sense of freedom.
You can wear button-up shirts
literally
again.
The happiest patient we have. Literally. They come in post-operative day 7 and they're smiling, even if they have discomfort. Over time, your body ages and the skin loses its integrity, and those breasts can droop again too.
Mm-hmm. Yeah, and the same is said for after a breast lift. You're going to continue to age.
Right, and also if you lose weight after a breast reduction, that's sometimes not great because then the top part deflates. And we've had patients lose a lot of weight after they've done their breast reduction and then have had to go back in and put an implant in. That's few and far between. We've had a few like that.
I can't think of any.
I have. I can. I'm not allowed to say. There's something called HIPAA. You may not know what it's about.
Yeah. Either or just lift it again. Like it's like people who get a tummy tuck and then lose 70 pounds. Like you might
at
need
the very
tummy
least
tuck.
lift. We've had more than a few of those.
Yeah.
A relift. We've had people gain weight. We've done a re-reduction.
Yeah. So it can happen. But your surgical results in most cases with a plastic surgeon are going to maintain as long as you maintain. But you're
get to a good weight beforehand, healthy lifestyle, no smoking, no drinking, positive thoughts, kombucha, nutrition consult.
Bone broth.
Yeah.
Bone broth. Bone broth for healing.
Kale.
Vitamin C.
Apparently, everyone now is so crazy about kale. Like everything, kale solves all problems.
Oh, I feel like kale is out. I feel like kale is so 2009.
Yeah. It's like the cocoa butter for me at cooking.
Kale is passe.
Maybe
we're all about
frisee kale and
now.
Cocoa butter.
Yeah.
Okay. So that's it. Breast reduction. I would love to say more. You really need to go to someone who is technique driven. It does make a big difference in your outcomes.
Oh my goodness, yes. We've seen some
really bad reductions.
Really bad scars.
And think about it. Like
even those patients are still happy though. They're not our patients, but
they're like, you know what, whatever.
Yeah, we're like, who did your breast reduction? Like it doesn't
it's very hard to see, but they're like, okay. It's okay. Don't be afraid. Scars are scars. You go to someone like us, the scars are going to be good. You're going to have a functional improvement. The recovery is not bad. You can get back to work quickly. If you're stay-at-home mom, be a stay-at-home mom quicker. Some stay-at-home moms don't want to go back quickly to being a stay-at-home mom. They want the week or two off.
I will write you a prescription for no vacuuming for at least 4 to 6 weeks.
To all family members.
Yeah. PSA. Mom is not allowed to do laundry.
This recovery is very difficult. You need to leave her alone.
Or dishes.
In her room.
Right. Bring her goodies. Take her for walks.
But don't fear it. This is actually breast reduction, even though it's not something we emphasize on our website. We should. To me, it's one of the most rewarding surgeries to do for our patients.
Yeah, it's very freeing.
Because you can see, you feel like as the surgeon that you've helped them and you've made a difference in their life. And that's why Amy and I do what we do. So I think it's a wonderful surgery. There was 85,000 done last year, and that's number 6. Maybe we can push it up to number 5 after this podcast.
There you go. Thanks so much, everyone, for listening to our podcast today. If you're interested in watching the video, you can follow us on our YouTube channel at Jason Martin, MD. And on Instagram, you can follow the Beauty and the Surgeon podcast at Beauty and the Surgeon Podcast. Also, Jason Martin, MD on Instagram as well.
And they didn't take down our pictures of markings for a breast reduction, so you can see that.
So those on Instagram?
Yeah.
Yeah, and leave us some comments, ratings, reviews. We really do appreciate it. We'd love to get feedback from anyone listening and find out what you would like to hear more about. Clearly, we had missed breast reduction and didn't know it, so give us some ideas.
There has to be some hidden surgeries out there that we haven't talked about.
What have we not talked about?
Or we're going to just rotate back through and start going through them again.
Right. Start from the bottom. We start with abdominoplasty first. A.
What was the first procedure we ever talked about?
Facelift.
Was that what it was?
Mm-hmm.
Yeah,
it was facelift. Yep, and then or breast augmentation. Those were either it was breast aug. I remember it was breast aug. Those were the 2 first ones though. Breast aug and facelift were the first ones we did. And actually, that old breast aug one actually is good. That one, that is a really good episode.
Which, by the way, like we actually have how many?
70? 65? 63.
We have 63 episodes. When we get to 100, we're gonna rent a hot air balloon and go across the United States with our faces on the balloon.
That'd be super cool. We should totally do that.
Yeah, we have 63 episodes, and some of those are really, really good. Actually, I think they're all good, but some of them are really informative.
I think they're all good.
So if you're someone who's interested in having surgery, interested in your health, interested in hearing from really interesting people that are in health and fitness and et cetera, you should listen to the old episodes.
Yeah. Dig through the archives. There's some
And
good stuff
subscribe.
there.
That's good. And rate us. Rank us and rate us. Okay.
All right. Thanks, everyone.
Bye.